University of Nairobi and Ministry of Health. That is very important for us. We will listen about that. After this, because officially you do not have this agenda in all of the agenda that you received. After that, I will talk a little about what is the plan for the next steps. And then we will have a wide discussion, what we have to do for the future. Then I know that usually now your mind is in your house. Yes, it is normal. Oh, I have to finish, I have to pack, and I have to go to the airport and see my family, my children, my others' family. But for the few hours, please be here. And we should talk about what we can do for the future and what is the next step that we should follow. Because I think that this is the first workshop on the AMR in Africa. Maybe it was other, maybe no. Then, anyway, it is very good to talk about this. If you have any specific topic, you can rise. Otherwise, I can ask our friends from Kenya to start the discussion. Okay.
Great. Thank you, Mohsen. Why don't we appreciate him? And I don't think it's been boring. I have enjoyed every single session. I think the beauty of data and interacting with it closely makes all the difference at the end of the day. And I think understanding where all that data has come from, for me, has made a very big difference as well. So when you talk about the Graham report, it's not something that's far off, but the fact that we have had 3 good days of going into it and looking at the microbe as well makes a lot of sense for us and makes a lot of difference. So today I think we are trying to address the so what. After enjoying the data, after enjoying the conversations and just deep diving into what the Graham report looked like, we need to find ways of addressing it in a better way or taking forward this conversation beyond the technical conversations that we frequently have and hopefully get to the level where we can get it to policy. And as I sat through the 3 days of discussion, I kept thinking about the different target audiences. Who would be best suited to have this data shared to? Maybe we can just start by sharing a bit of that. Who do you think needs to hear about this data and why? I have no ice cream, disclaimer. You've been getting ice cream every single day, so today there is no treat. Maybe nyama choma, Prof. Thumbi. Nyama choma is our grilled meat. Okay. Is that better than ice cream? Maybe. So who do you think would be a good target audience for all the data that you've interacted with and why? Yes, Emiliana. Okay, policymaker, and policymakers are in different categories. We will unpack that as well. Yes, Ibrahim.
I will target politicians.
You will target politicians. So what part of the data would you use to target your politicians?
I would want to have like the real patient resistance data that brings out the impact of AMR on patient outcomes.
Patient outcomes for the politician. Okay, I see. Yes, Ron.
We would also need subject matter experts who can interpret the data in a language that can be easily understandable to politicians and the policymakers. The raw data is perfect, but we need someone who can, for stakeholders, subject
Okay, while you're on that, who's your subject matter expert?
That to be data analysts in a country. That to be people who draft policy briefs for the ministries. That could also be technical working groups within the AMRCC.
Okay, great. Ron?
So I just
Thank
wanted
you.
to add that while the policymakers are also important, I think that just critiquing the data so far has also emphasized the need for us to go back to who the people who generate the data, because they need to understand why that data is being used, how it is significant for their patients, for example. So those prescribers, lab personnel who are collecting the AMR, breakpoints and all these things. So I think those are also important. So we need to actually tailor make, sort of, tailor make a package for them as well. Thank
Okay,
you.
great. So you have the people who generate the data. This side is quiet. I'll come back. Any other target audience? Okay, Ibrahim, for the last
Yeah,
one, then I'll
just
come back to
to
you.
supplement on my colleague's submission. Yeah, the social anthropologist. All of us seated in this room could be scientists. We understand like preaching to our own already converted. But how are we going to break this message so that it can be taken up by a politician, by a non-scientist, and get the real meaning of the outcomes or impact?
Okay, thank you. So we'll take the last submission. Thank you. Okay, thank you. I see two more hands. Those will be the last ones, then we'll move. Thank you.
So thank you. I am a very late attendant to this conference, so I do not know what preceded. I work at a hospital, at Moy Referral Hospital in Eldoret, and all I would say in terms of policymakers is we have incredibly high gram-negative resistance at Moy. The problem doesn't happen at MTRH. Sorry, that's the regional referral hospital. The problem happens out in the community because people are taking antibiotics from the chemists and the pharmacists, and there is supposed to be enforcement. So I realize I'm saying something Kenya specific, but my guess is that this is happening in the regional countries as well, that there's laws on the books that limit what the chemists and pharmacists are supposed to give out, but they're not being enforced. It's the policymakers that really need to know this, because if we can't stop that problem, at least in Kenya, we're going to continue to see gram-negative resistance in the hospitals and in the clinics.
Thank you. So the last one from Chizimu, then we'll have more discussion as we proceed.
I propose this can also be shared to the key hospital leadership at all levels, because these are the ones who lobby for resources and ensure that these results are nicely generated. Thank you.
Okay, thank you. So there's one target group which I haven't had. I wonder when we'll have for this. Let's see who gets the nyama. Okay, I'll take your submission. Yes. Thank you.
The patient is,
Thank you.
the patient is the community leaders should be the target because they are the one. Over there you develop a policy, regulation, whatever. If the community is not embracing, things will not go the right direction. So the community should be engaged, well informed, and be part of the initiative.
Okay, thank you. Is that what you also wanted to say?
Yeah, I just think that we are missing, there are a lot of advocacy groups and NGOs and institutions who are, common friends in many of our countries. I mean, many of them probably because are not much aware of gram data and the utility for them as an advocacy group.
Okay. Great, thank you. So you can see how this one set of data can speak to so many of our stakeholders depending on what you pick and how you communicate that piece of information. So this morning we just want to look at some of the policy needs in the region, and we are all here because we have national action plans that we are implementing within our countries. And I keep making reference to 2017 when a lot of our countries developed their first version of NAPS. We had a lot of pressure, or rather we felt a lot of pressure from the global level to put together action plans. And a lot of them were guided by this blueprint that was a global action plan. And it's been 5 or 6 or 7 years implementing the first version of our NAPS with a big focus on generating data on surveillance. We are now in the season where a lot of our countries are developing their second versions of the national action plans. And one of the questions I've been asking myself this week, has external data contributed to the review of your national action plans? Has it found its way into your background sections, for example, to try and build the body of evidence that you have, or we used local data? Apart from the national level, at the Africa Union level also, there's a framework that was developed for AMR, and our leadership made commitments to implement actions within our NAPS. And one of the other frequently cited challenge when focal points are making presentations on progress in implementing national action plans, when we get to the challenges section, 2 key challenges frequently come up. One is inadequate data, and the second challenge is the lack of political will and commitment. And yet we have our leadership sign on into regional, global, and national level documents that actually show that they actually have goodwill. But how do you measure commitment? Is it because of allocation of resources? And if this has not happened, why? And if the data that we've collected over the last 7 years is not able to propel us to the level that we can convince leadership that this is actually a problem that's worth investing in, then it becomes a problem. And I really liked what we did yesterday. The cost utility effectiveness model is so critical, so that even when we go in to talk to your leadership, we're not just telling them we need to invest in infection prevention and control. How much am I saving by investing in IPC? Not just saving in terms of money, but we saw from the data, you can actually even be able to provide estimates of how many lives can be saved by investing in a certain intervention. And that would be good feedback for your politician who is not interested in Staph aureus or or Acinetobacter, because when you begin that, you lose them. But when you talk people and money, then your policy audience is captured. So when you go to the clinicians, we can talk about Acinetobacter. They would pay attention. When you talk about money, it's none of their business because they are not the ones who are responsible. So we have all these declarations that we've signed on to. And recently, the UN high-level meeting on AMR, and all our countries agreed to the 10% reduction. And I think we have a good fallback position, because I remember during the discussions on whether or not at a regional level we can adapt the 10%, one of the key questions that came out was 10% from what? Do we have a baseline? And many of us felt we didn't have a baseline. But I think we have a baseline. Do we agree that we have a baseline? It's not a resounding yes. Some people still feel they don't have baselines. Do you have a baseline that we can work with? Yes, and I think that's important to recognize that we have data. It's just that we probably did not have an opportunity of exploring the data. So we have those that have developed, of course, and one of our key problems has been funding gaps. We've talked about interventions. Our national action plans now are well costed, thanks to the WHO costing tool that shows us what every sector is supposed to contribute to the effective implementation of the national action plans. But we have less than 10% of countries funded to implement the NAPs. And I don't know why the funding is not flowing towards AMR NAP implementation. Maybe that's something we will get into discussing when we look at the way forward. The good thing is that you have a plan, but having a plan and implementing it is something else. And I think we need to think about how this kind of data can spur funds to flow from one part of the sector into implementing the national action plans for antimicrobial resistance. This was this was interesting when I picked this from the Fleming Fund site. Some of our countries are under Fleming Fund. And I am glad MTRH is here because a lot of the sites, surveillance sites in our countries, these are the sites that are generating surveillance data. These are the sites that are possibly implementing very strong stewardship programs, hopefully collecting very good antibiotic use data at some point. So that also means they have expertise, they have capacity, they are seeing a lot of patients, different conditions. So this is the kind of surveillance data we are seeing at a national level. And one of the things I think you would agree, if your hospital is part of this Sentinel site, and that surveillance data is being generated for decision making, is there something that needs to change? Because if you're making decisions based on Sentinel surveillance data, are there pros, are there cons? And if I'm going to rely on this kind of data to make or review my standard treatment guidelines for the country, is there a problem? Is there not a problem? And you know your countries and you can see your maps and what kind of hospitals they are and the kind of resistance data that's being generated. And we are saying this is the data that's going to inform the review of standard treatment guidelines. Would there be a problem? Any thoughts on that? Yes, it's data and it's good data because we are working on quality as well. So good quality data from your Sentinel surveillance sites in your countries, and you can see as they are distributed what levels of hospitals these are. So what kind of patients you're seeing is also very clear. So the resistance patterns that will be reported in your national level report will also have a ripple effect. Are we happy? Yes, I hear yes. No. There's a voice of dissent. And we have to defend our answers. It's good because we have begun to have our surveillance systems up and running. But for purposes of decision making, when we say evidence-based treatment guidelines, so the kind of evidence that you're generating from the surveillance sites, is it adequate? No. Why no?
Reflecting to Tanzania, we have few sampling sites, and these sampling sites, they're like tertiary hospitals, and we don't have sampling sites at primary level hospitals. Referring to Prof, when he was presenting on the first day, he said that at least the good data for estimation should come from the primary health hospitals. And also, looking also at the map of Tanzania, you see that also the Sentinel sites, they are not representative.
Okay.
Look on some regions, there are so many, and in some regions there is none.
Okay, great.
So there is a bias.
Thank you. So the whole aspect around representativeness of the data, does it truly reflect what we are seeing in the population? I think this is something else that needs to be addressed. This is a very good start because yes, it's giving us information, but is this adequate enough? Do we need to spread further and gather more data and have this data collected in different ways so that we can be able to have representative data within the country to inform decisions ultimately at the end of the day? So I think as we move, and this is similar to the previous slide. And yesterday I also asked our questions. Are we asking the right questions about surveillance in our country? What do we want to answer? And what do we want to change? And I note that there's been significant improvement in terms of microbiology capacity. And you can see even for Tanzania, yes, you have an increase in the number of isolates that are reported to the national level, increasing from 4,000 in 2020 And in 2023, I think we had about 48,000. Significant increase, meaning the interventions that we have put in place are probably working. Hopefully, clinicians are making more use of the laboratory compared to before, rightly because you built capacity in the labs and they're finding it useful. But as I looked at this data, and I know this is what is reflected in a lot of our reports, I asked myself, is this data enough for me to sit down, analyze, and make meaningful decisions at the policy level, whether it's influencing treatment outcomes, whether it's influencing resource allocation, whether it's influencing policy reviews or the development of strategic plans across different sectors and disciplines, even within the same sector. And I felt we needed to do a little bit more work when it comes to generating our reports, interacting with these reports, and not just limiting ourselves to the AMR scope, but also looking at other health programs within the sector that could be impacted by the data that we are collecting. So if you looked at your data by sex, by age, are you likely to pull in other non-traditional technical working group members, for example, into your team? And I know the way our technical working groups are composed in our countries really go by the expertise people have in AMR and not necessarily representing other programs or disciplines or departments within the ministry. And I think by looking at our data more in more detail and interacting with it a little bit more, you realize you need an extra stakeholder. For example, if you've not involved your HIV teams into your technical working groups, is there something they can do with your data that will actually support the implementation of your NAP? If your maternal and child health teams are not on board and you're seeing a lot of resistance in under fives, for example, or mortality in under fives because of neonatal sepsis, and yet they are not part of the conversation, are we missing an opportunity? So I think by looking at our data in a little bit more detail, it's actually going to give us better information on who needs to be on that discussion table, apart from those traditional technical working groups that we have constantly had in our conversations. So this was a report that was released, I think, for Kenya, the 2024 report, and I think it was an improvement from the previous year, because the previous year just reported on drug-bag combinations. But over the last 3 days, we have seen there's more to reporting other than just bag-drug combinations. There's a lot more that you can pick. So this report included interventions in IPC, interventions in stewardship, interventions in reviewing the trends on resistance, and that's based from the lab reports. So it keeps improving by the day. And the more you have data addressing different aspects of your national action plan in one place, I think it makes it easier for decisions to be made based on what is being viewed. I picked this report on IPC because over the last 3 days we have made a lot of reference to WASH and IPC as key interventions that have high impact and low investment based on what we could see on trends of resistance over years from the data that was shared with us. And I think by looking at this report that was done by the WHO last year, we have some critical areas that are flagged from flagged out in our region, like trying to determine the burden of healthcare-associated infections. And we talked about antimicrobial stewardship. And one of the weaknesses we saw in our data is that what we were bringing out more were process and structure level indicators and outcomes, but we were not bringing out patient-related outcomes or microbiological or any clinical outcomes were not actually being documented. So if you're able to document HAI prevalence, for example, in your facility or in your region, I think it gives your data a whole new level of meaning. Because when you begin to ask for investment in a particular aspect, like hand hygiene, for example, you're not just making it up, but you're actually able to determine that hand hygiene has contributed probably to 80% reduction of HAI in your hospital. And I think that for any policymaker who's responsible for allocating money then is able to understand why you need that intervention to be sustainably funded. Last year, the Africa Union, through the Africa CDC, launched the landmark report. And this landmark report also brought out some critical aspects that we felt in our region needed to be addressed. And that's why having region-specific data sometimes helps you to further sharpen your prioritization in terms of what you want or where you want your investments to go to. And we have had this again over the last couple of days, that for one of the major drivers of AMR in Africa is poor sanitation. And if we don't invest in this, it doesn't matter how many new molecules are developed, because they will still find their way, and the development of resistance will still occur. And you can see for IPC program and IPC and WASH programs in terms of implementation, as per the WHO guidelines, and this is just the minimum requirements for implementing IPC programs in healthcare facilities, the average score for Africa was like 13%. And you can see, compared to the rest of the world, this should not be news to us, because we are familiar with our facilities. And yet, investment in this particular area will yield a lot of results ultimately, beyond just the AMR aspect that we are working with. Building evidence and improved reporting, as you can see, still had a problem in terms of setting baselines, having adequate technical capacity, having the necessary resources and systems to collect data across sectors. And this is not just from the landmark report, but also from TRACS. TRACS is your annual self-assessment that you submit to the quadripartite. And we have reported over, I think, the last 3 years consistently that we do not have the technical capacity. But I think with what has happened over the last 3 years, I hope we can go back and begin to build that capacity in country. One, to not just collect the data, but analyze it and make some meaningful interpretation out of it, and not just in one sector. Like I know our animal health colleagues were asking what is happening in human health. We have a big challenge when it comes to the systems, and that goes with capacity and setting baselines. If you can't set a baseline, then you can't have a target, because where are you working from? It becomes very difficult. So that was an area that was a bit of a challenge. And the final one that I'd like to highlight is governance and the use of data. You can have good leadership, but if your leadership is not aware of what your data is saying, then it will be reporting, it will be narratives and narratives, but then when you don't have hard numbers, it becomes hard to work around that. So those are some of the things I thought needed to be picked out. And just to go back to from where we are coming from to the outcomes of the high-level meeting on AMR and what the country is committed to doing, and also bringing this back home, because we say after they have signed and after they've read your statement and after the declaration has been adopted, what next? It comes down to the technical people to make sure implementation happens. The reduction target, I think the AMR-related debt, and I say that has already been adopted by all your ministers. So it's up to us to work out how we are going to do that. That means the kind of interventions we are going to select need really to be working towards reduction in debts. And as you see, we don't need to just worry about it within our AMR circles, but we need to spread wider into the entire healthcare system and see how does it also impact on the reduction in AMR-related deaths. Of course, the aspect of funding has been long-standing, and as we go back, what data can we use from the Graham report to advocate for more funding? And how do we package that data? The problem is not in having data. The problem is in reframing and repackaging that data so that it speaks to the target audience that you want to move towards a certain direction. And of course, the aspect of One Health, consistently emphasized, and of course, looking at accountability. And of course, the ministerial meeting that followed in November in Jeddah also adopted the UNGA declaration, so we are not really going to run away from the targets that we have committed to making. So I put this up here. This is the costed action plan for Tanzania, 2023 to 2028, and you can see they've allocated money And as I looked at these costed naps with a new lens yesterday, I was asking myself, how did we select these interventions? What guided, or was it our usual workshop, our usual training? Did we think about the overall impact of the intervention? Was there any evidence that actually guided the selection of those interventions? Because we realized that maybe in the last NAP, we had this intervention, it didn't give us a good result. So I was just thinking about how we can better use our data to really inform the kind of interventions that we are putting forward. So this now brings me to our status as we are in our countries with all the information that we are gathering. And I wanted to ask, maybe for the countries that are represented here, we are at different levels. On the right hand, you can see the pyramid that has data, information, knowledge, and wisdom. I found that bit on wisdom very interesting. I didn't think about it as wisdom, but they say wisdom is the ability to make well-informed policy decisions. Well-informed, meaning you've gathered a lot of intel and you're able to make your decisions wisely. And I asked myself, at what level is my country on this pyramid? What level is your country? Data collection? Are you on analysis, contextualization? Have you gotten to health reporting? Have you gotten to knowledge translation? Have you gotten to evidence-informed policy making? Honestly, assessing your surveillance systems. Where are you at? Let's hear some responses. Where are we? I can see South Sudan. Abe is actually laughing. Let's hear where Sudan is, South Sudan. Where are you? Where are you on the on the left-hand side? And we are here because we are all walking each other home. So it's okay, it's a long journey. We've started with one step. Where is South Sudan? On the left-hand side. Some wisdom is there. That means you've already surpassed the data collection. You're no longer collecting data. You're wise. Is there any other country that wants to share an honest opinion of where they are? Zim. Bless more.
I would say we are on information, trying to analyze, contextualizing, and yeah.
Okay, so you're on level 2. One up from data collection, analysis and contextualization. Fair enough. Zambia.
We revised our standard treatment guidelines based on the data we have generated.
Okay.
Thank you.
All right. So that means we are beyond health reporting. We have done knowledge translation and now gotten to evidence-informed policy making. We went through all the data analysis, reporting, knowledge translation. That's good. Any other country? Yes?
In Eswatini, I may say, yes, we are at the knowledge level,
Mm-hmm.
but some activities like change of practice, clinicians practice in facilities, and we have also national data dissemination workshops where we engage even to the ministerial level. We have sharing our data also to the high political leaders, even the prime minister of the country and the different sectors, the major sectors. So, but synthesizing the data to change policy at national level, we are working on that.
Work in progress. Thank you. Final submission on this?
I want to say that for all these pyramid steps, perhaps the extent to which we are implementing our activities within each domain is also important. Example, for Ghana, perhaps we are straddling between information and knowledge. But again, we're doing a little bit of information, we're doing a little bit of knowledge, but there's still more we can do within each of these strata. But yeah, for Ghana, I think we are between information and knowledge.
Okay.
We go up, we come down, we go up, we come down. Yeah.
It's fair representation. Finally, Malawi.
So I just wanted to complement his answer for Malawi's case. I think that also another area that we should think about is the type of data we're talking about. So for AMR data, for example, because of political strategies or let's say priorities, AMR data was the first thing we needed to have that data. So I would say we are in advanced stages in that case. So we've got evidence-informed policy making, policy decisions. But when you look at AMS, for example, so antimicrobial usage, consumption, that is an area where we're maybe a few steps behind. So maybe it also emphasizes with what our priorities are and what type of data are we collecting. Now, when you look at burden data, for example, this is an area that we are now looking into collecting and looking at protocols and how we move from there. So I would say it also looks at it also this really gives us a perspective on the type of data that we are prioritizing to collect and translate into policy. Thank you.
I hear Nigeria consulting. they, they want to say something. There was heated consultation in Nigeria.
Yes, thank you very much. And it's interesting actually. The pyramid, if you contextualize all that is here to what happens in Nigeria, you see that knowing fully that AMR is a One Health or quartet approach that you need to do. So across all the, I think the different sectors, you can say different sectors are at different levels. That's how I see it. If you take the human health, that you can say we are probably up there around the knowledge and wisdom part. And then also if you come to, let's say, environment, which often is the part that in Nigeria needs so much support to actually come up to the level of the others. I think that will be struggling between probably data and information. And then for animal health, if you pick that, you see that that will be between information and knowledge. But then certainly if you add all of that, you see that it's a fluid sort of thing. And how I see it is the whole national AMR program will probably be around, we'll be moving between the knowledge, touching wisdom small, and then coming back to information sort of. That's my idea. Thank you.
Thank you. Because this, okay, the last one from Zim. Mashe.
Okay, thank you so much for your question. I still feel we are using a wrong approach for the AMR program. Let me share my submission. Because your question, as it stands, and what I've heard from people, they're commenting on bacterial resistance, not AMR. Okay, let me qualify. Because if you check, in most countries, the HIV program, they have been tracking resistance of ARVs to HIV. In most countries, they've been tracking TB. They have data. They are even at wisdom, even above wisdom. If you go to malaria, there is a lot of information that is there. So our approach, even up to now, even at a global level, is to focusing on bacterial resistance, not AMR. So my submission is that let's combine all the efforts in a country into one pot. Let's bring in the TB guys. Let's bring in the HIV guys. Let's bring the malaria guys, and also the bacterial guys, and work together as a team. One step, we can combine the resources. There's a lot of money even at the global fund level where you can leverage on some of these bacterial, whatever work that we can do. So at a global level, we are still using a wrong approach to AMR. What we need to do is to bring all sectors, all organisms in one pot. Then we talk of AMR. But as it stands, Evelyn, we are talking of antibiotic resistance,
Yes.
which is not AMR.
Submission received, and Letitia is on the call from the WHO, and I think she has taken note, and I know that has been a big discussion. It's not just here, but it's frequently brought up. Why are we isolating bacterial resistance and leaving out the others? Of course, there are many schools of thought around that, and there are reasons why probably investment has gone into that area, and also the not just investment, but also the focus. It's because of the capacities that have existed in countries for years. You really can't compare, but yes, you can definitely leverage on the investment that has been made in HIV, AIDS, TB, and malaria. There's a lot of learning. There's a lot of infrastructure that has been built. There's a lot of capacity that has been built. So it's up to the countries to find an appropriate entry point to leverage all the work that has been done in country. So we can move to the next level. Of course, as we make our decisions, what are those sets of data that you require to make your operational level decision? You're at the clinical level. You need this data for action now. Management needs to act on your hand hygiene data. Management needs to act on your HAI data, for example. And then you have your policy makers up there that are executives that need to work on your overall burden of AMR, the deaths that are related to AMR. What are they going to do with that information that you've given them? The overall consumption of antibiotics in the country. You've categorized them by the AWARE classification. The teams that are responsible for developing the essential medicines list or the essential diagnostics list, what are they going to use that data for to make their strategic decisions at the level that they are in? So we are going to just run this short Mentimeter session, just above a short buzz session, to see where we are. I will stop this and see just how much this is wrong one. So if you could just take out your phones, and for 1 minute, we will try to respond to some of these questions. Dr. Tanui would have been here this morning, but he sent his apologies, so this is on behalf of Dr. Tanui. You can just scan the QR code if you're able to. Are we in? There's no ice cream. I have to keep saying that. And there's no, oh, Martin says there's ice cream.
Janet is here.
Where is Janet? I'm here. She probably has another notebook, so let's see. Are we all in? Okay. So let's take this quick one before this training. Okay, are we 18? Are we 25? Okay, I see the numbers growing. So we can see a very rich resource. And I remember the launch, and I think that also speaks to our dissemination methods for the team at IHME and our other partners. When you have an important report to disseminate, what channels do we use to make our reports known, our publications known? Or do we assume that everybody will just go to the website just because, yes, you've shared a link? You've also shared the infographics that we can use for our presentations. Is that enough? And how well can we have our dissemination plan structured to make sure that such critical resources go out to the people who need them the most? So I think sometimes these are some of the questions we grapple with, not just for this particular one, but even for the publications we have in country. And even the strategies like the NAPs that we are developing, a lot of times, they're only known at the national level. When you go down to the facilities, some people probably have no idea that there is a NAP. They probably have no idea that the sectors are supposed to be working together. So this is just on dissemination. And what is it that makes people not to interact with work that is published? I think those are some of the things we need to get to the bottom of. Then the next one, I think we have about 3 of them. What do we perceive as our biggest challenge to the effective use of this Graham report? Do we anticipate any challenges? Maybe we can see what we perceive. Once we are out of here, like we said, so what? We've received a lot of capacity building, and now we know what is in the microbe website. The global burden of disease is rich, but what would be our biggest challenge to the effective use of this resource? If we could just maybe type in a word or two. Are we able to type in? Okay. Let's see what we perceive as our biggest challenges to the effective use of the Graham report, and maybe not just that, but other reports that will be coming out. Okay, so I think a few themes are coming out quite strongly, like capacity, knowledge and technical capacity go hand in hand. Awareness, same category. Lack of information is also part of awareness, understanding, applicability, data availability. So you can see there are a whole lot of challenges that actually would bar people from effectively using this data. So maybe what we can do is just take these responses and analyze and see how we can bridge this, because maybe at the end of this year there'll be another report out, and we want to see better uptake of the report and use of this data that's coming through these reports for policy use and action. So the last one, I think this is the last question. How can this be improved to provide more actionable insights? Is there any improvement that you'd like to see from this particular report that was shared and from the 3 days of learning that you think would make our work easier when we go back to our respective hospitals or go back to our respective ministries or organizations, because we all represent different levels of policy making. So someone says make it simpler. So to the team, we begin to think about that. Virtual Graham courses, which is good. Training, dissemination, involve the policy makers. So probably just thinking of how we can summarize our very good data into policy briefs that can be appreciated by policymakers. I know we have policy briefs for each country that are still a bit technical. So maybe if this can be accompanied by a simplified policy brief that brings out key data points, like what is there on the global burden of disease website that says 20 million people died because of, it's simplified. I think it makes it easier. And you can see training also is gaining a lot of traction as well. User guide, for example. Do we have a user guide on how to navigate? Yes. We have. We can add. So these are some levels or some suggestions that can be taken in just to support the teams to action the data a little bit more confidently once we are back in our respective areas of work. So we'll also just summarize this and allow us to synthesize the information. So I think that was the last one. So we can do this together as we all head back to our institutions. So as I bring my presentation to an end, this guy is not going away. Okay. So I'll just go back to the slide set and summarize some of the challenges or potential gaps that we see trying to find my slides. So some of the policy gaps that we are picking out as we have this conversation is the need for resource allocation due to data gaps. But I think once we use our data appropriately, we might actually find more efficient ways of allocating our resources, just like Marshe pointed out. And I think the other thing that has come out strongly over the last 3 days is that you have multiple streams of evidence that we can use in country. But what we see is insufficient collaboration between the research institutions, healthcare providers, and the policymakers. A lot of papers are being published, but who's the custodian of all this data? And are we using it even at country level to know what's happening? And we talked about economic analysis. I will not overemphasize that. And then, of course, the other aspect is on health disparities and equity dimensions, and the whole essence of bringing in the social anthropologists to be part of these conversations, so that we also just move beyond the technical aspects and also look at the social dimensions of implementing our work. And that will affect the kind of data that we collect. That will affect the design of our data collection tools and the design of our surveillance systems. And we've already spoken to targeting communications and interventions. That will ultimately spill over into timely data utilization and also just having national data reporting frameworks. I don't know whether our countries have data reporting frameworks. In the first version of the national action plans, the team that drives data and M&E and communication was very weak. We focused a lot on the technical bits like surveillance data, like stewardship, IPC, and awareness, but we forgot that we need a team of technical experts to actually analyze our data and help us communicate this better. So you've brought this out very well in terms of the capacity that is required, the need for sharing data so that we don't wait for publications before data is shared. I think that has also been a big problem. And of course, the legal consideration for data governance, especially if we would want to see data shared across countries so that we appreciate regional differences in the trends that we are seeing. And then there's a bit on public access to AMR data. How do we balance open data sharing initiatives with confidentiality and other ethical considerations? We have great opportunities and the rich resources that are available on the sites that have been shared over the last 3 weeks. And in addition, we have others that are also available. I think what we need to do is just make the best use of the opportunities that are available. So as I end, some key questions that I will keep asking as you go back to look at your data generation systems or your data management systems. Are we asking the right questions? We all started because we needed to collect data. So what data are we collecting? And is it answering what we want answered? And are we interacting and interrogating our data enough? It's not enough to say we are now pushing 43,000, isolates, or we are reporting this number of tons of an antibiotic that has been used. What does that mean? Are we interacting with it? Are we interrogating? I remember the heated conversation with Zambia on the top 10, causes of uh, was it morbidity or mortality in Zambia, and we had a heated conversation. That's because we had an opportunity to interrogate this data. And what's our entry point? It might not be your AMR program because it's not funded. You can find an entry point through the HIV program or the maternal and neonatal child health program. So what's your entry point? And I think the other consideration that also has come out clearly is that we need the right expertise on the table. For you to have good policy impact, everyone needs to be around the table above the technical expertise that we have conventionally seen in a lot of our coordinating committees and our technical working groups. And of course, the place of cost effectiveness and utility tools, I think that cannot be overemphasized. And where we are now, if we are to stimulate investment, then this is an absolute necessity for us to have in our policy conversations. And I will request to stop here and hand over to Motion for the next session.
Okay, we have two ways. One way is that having break. One way is continue our discussion and break will be included in our discussion. Which one do you like? Because we have some people in the Zoom and some people that wanted to leave, then maybe you should decide that what do you want. Okay. One sec. It was not very nice, but I have to say. I think that maybe I have to. Okay. I, I have to say that we are in the wrong way for the AMR. Because unfortunately, there is this idea that AMR is microbiology problem. Some others say, no, it is clinical problem. Some others say, no, it is surveillance problem. All is wrong. AMR have to be a comprehensive action plan that include clinician, include microbiologists, include health system manager, health system management, have to include people that working on the data, and have to be include policymaker. Why? The, the worst thing is that you say that, okay, no worry, we have glass, and glass is enough. No, glass is not enough. Having glass, just having glass, is a big mistake. Having a good surveillance is a good mistake. Having that, okay, just we gather clinical problem is a mistake. We have to think that, okay, we cannot eradicate AMR. AMR is with us. It's with us. As long as we are alive in the earth, we have AMR. Because we have fighting with the bacteria, with the virus, with the fungi, with the trophozoite. They are alive. They are trying to be alive against of us. Okay, any antibiotic that you use, they make other things, and they will be against of you. Then eradication of AMR, at least so far, is not in the vision that we can see. AMR have to be a comprehensive process. It means that it has to include clinical pattern, microbiology pattern, lab result, the discharge situation of the people. Okay, we are having many things. We have GLAS, we have ACOR. Fortunately, yesterday, Professor Ben explained different surveillance system that we have, but it doesn't work. And one other big problem is that AMR is moving to the corner of the Ministry of Health. Usually, no. Minister, do you know? Do you know that you are working on the AMR? Yes. You are very lucky person. You are very super lucky person. In many countries, minister, because we summarize our work to the microbiology, to the surveillance, to the information that we get from the clinic. Then we have to change our approach. We have to think, okay, this data that I am gathering, my first target, who is my first target? Who is my first target? Patient. The patient. Patient? No. Poor patient. Who is my first target? My first target is doctor that work in the clinic. That, okay, doctor, no gram-negative, please. Consider that gram-negative is a big problem. Streptococcus pneumonia, if we vaccinate, it's going down. Staph aureus is going up. And you should know doctor. Did you think that you send your result for the doctor? Did you get any feedback from there? Sometimes. Anyway, our second target is health system management. Our hospital is the midst of the worst pathogen. Anybody go to the hospital safe with some problem will come back with the many problems. Did we talk about that? We as long as you have a very bad place with the name of the hospital, yes, I'm going to present it was 2 days to us. Some order was there very bad against this antibiotic. The second object is manage it, how we can fix the problem in the hospital. What is the that are your charge? You saw, and I can show you again if you want, you saw the best action we for decide, buy, and apply. Public health people. In the end, for the providing money, for the providing many things, is and talking with the pharmaceutical company, do not go to this head that, okay, you should work with the pharmaceutical company. Pharmaceutical company love you because you provide data for them to get money, to get subsidized from the government and making antibiotic with a really very expensive price that nobody cannot use. The best process is that working on the environmental, you saw many people here mention about the environmental intervention, like water and sanitation. Let me say, I published a paper last year on the causes of death, because my main work is in the causes of death. And I showed that Eastern, Sub-Saharan Africa, 17 years increased life expectancy from 1990 until 2021. Maybe I made mistake 70. Ethiopia, it was 80. But I can't remember exact Sub-Saharan Africa. Oh. Okay. And when we look, 6 years of this was from diarrhea. You control diarrhea. What is AMR? You control diarrhea. You decreased mortality from TB. You decreased mortality from the HIV. You decreased mortality from meningitis, from lower respiratory, from many things. And now your life expectancy in Eastern Sub-Saharan Africa is high, much, much higher than Western, Southern, and Central. Okay, all is due to the intervention. We should, with the AMR, show to the policy, to the public health people that where we need intervention. in which pathogen we need intervention, in which hospital, in which city we need to improve hygiene of the hospital. You keep people 10 days in the hospital. No, people have to come and go. Why they stay in the hospital a lot? Getting something that make a problem for everybody? Okay. Then don't forget that we are not working with this for pharmaceutical company. We are working for the people. And the most important person that we have to give them service is the doctor that working in the clinic. Second is health system manager. Third is public health manager. Fourth is policymaker. If you are doing this, you are doing correct. And all of them is not possible to calculate just based on the surveillance. It's not possible just to do based on the gathering data about the antibiotic use. Okay, antibiotic use doesn't change anything, but it is very important. Surveillance is very important. GLS is very important, but is not the problem that is not the thing that fix the problem. And slowly, I will go through the question. Let me say something that I noted to say here. Okay, when we consider AMR as a comprehensive process that starts from patient, doctor in the clinic, lab in the clinic, data manager system, data management system, and then people that working in the management of the health system, okay, we are, and public health, we are in the good way. Then any data that we gather have to include all of them. Don't go to this trap that, okay, get number of the pathogen in the bloodstream infections that are resistant to this antibiotic and finish. It is not AMR, but it is necessary. Okay, let's go what we are doing, we as a group that working in AMR in global. First, we made microbe that I want to again show this, maybe share with you. No, sorry. This was yesterday I showed to you that, okay, AMR is not separate from burden of disease, because burden of disease will say how many steroids do you have in this country, and then how many percent of them go to the hospital, and how many percent of them get the upper UTI or upper lower respiratory infections, and then how many percent go to the micro, how many percent of these people get the pathogen that is resistant to this bacteria, to this antibiotic. Then should use GBD compare as a all the time. But let me again, I am trying to find my friend microbe. Okay, you can see in the micro, is it coming? In the micro, we calculated by country, by age, by sex for you, by the year and time frame, distribution of the pathogen, distribution of the drug or combo that are resistant, and then we gave you something that, okay, what is the top pathogen in your country? Top 10 pathogen by the infectious symptom. And then we showed to you what is the drug that is resistant to this bug. It is something that we did. We will add to this process that we made to the microbe national antibiogram for every country. We will add soon. After 1 month, 2 months, you can see national antibiogram by the infectious syndrome and by the all infections. Here, I think that maybe if you share a brief policy, we made 4 pages, 2 pages, not for you just, we will give you, but for your minister, for your parliament. And we will set for them these pages that, okay, what's going on in your country? Maybe they don't know. And sorry, I was sick last night. Okay, what is going on in your country? And we will show to you now, and you can say it is good or bad. What we should add or not. It is complicated or it is simple. Then we will share with you. And any other thing that we can do for you, you should say. And also, I am asking all of our friends that are online, if you have any idea that how we can make our work better, how we can make our information more transparent for you and distribute all of the things between you. But what is your expectation from us? It is open, free, open discussion. You can say everything that you did, it is useless. I have to go in this way, in that way. Or you can say any other thing that you want. But please look to our microbe. Yeah, 1 second, I want to again show, let's say this time go to the Ethiopia. Yesterday, we were all the time in the Kenya. Okay, you can see in Ethiopia, 370,000 people die by sepsis, and 130 of them was by bacteria. And what was the bacteria that they died? This is the bacteria. This is the number of the deaths bacteria that they did. And what is the pathogen? What is the biggest problem for them? You can open these. This map, it shows you that, okay, what is the top pathogen, what is the top antibiotic? This is good for the clinic, especially. We are doing this, maybe 60% of our goal is to help clinicians that they don't have lab. They have to decide now. They have a kid with the lower respiratory. What is the top pathogen? And what is the top antibiotic that they can use? This is our goal. Any data that you give us, we will add here. And we will make it improve. Sorry. Okay. Then, first thing that I am request from you, especially from the friends that are online, that okay, we are, at least based on the budget that my team has, we can run one other time AMR and improve this micro. And hopefully we can get budget for the running every year based on the new data, based on the new method, based on the everything that we get from you. Just you should say to us what we have to do. You are in the field. I was in the field 30 years ago. I am not anymore in the field. You are in the field. You know the problem. How we can improve, especially from the friends on the Zoom. Okay, is there anything that I have to say before go to the discussion? Okay, this is for you. First person, can you check that is there any hands up in the friends in the Zoom, because I cannot see that. Okay, what we have to do? We talked with you 3 days. We can improve AMR, at least for the one other round. And for sure. But for the other round, we will try. How we can improve? In the way that can help you not as a AMR people, help you as a people that think about the doctor in the clinic, manager of the health system, people that working in the lab, people that working in the public health, how we can help. Please. Then, okay, we can go on. Yes. Ghana.
I would say this based on my personal experience with Graham. Before we came here, I have been looking at the microbe page, but I had actually struggled to understand a lot of the things there, some of the pages and how to interpret the information there. But here, I've gotten a better understanding. And of course, not everybody would get the opportunity to be here. So, what perhaps personally I would expect more, I mean, it's fantastic, super, super, super. But perhaps on every page, on every possible diagram or table, some explanation how to interpret the results would be helpful. I've gathered that interpretation from here, but I guess for someone who is not here, they may also be going through the challenges I went through. Thank you.
Dear Chair, can you write it down that one important topic that we have to work on that is tutorial and is explanation for the each page, that if anybody wants some explanation, click on the explanation and explain the detail. Thank you. We will
Welcome.
do that.
And then two, yeah. Also from what I've learned here, I think one of the things I've really enjoyed learning here is the fact that we could develop our country antibiograms from the data set that is available. But hopefully, if Graham could also do this on our behalf, so that when you go to the site, you click on Ghana, and there's a table on antibiogram. So that we don't have to perhaps do that on our end. We might misinterpret the results and do a wrong antibiogram. But if this comes from the experts who have developed, who have provided us with the data, that would be super helpful.
Okay?
Thank you.
Antibiogram. Dear Chair. Okay. Any other? Yes?
Yeah, thank you. On the antibiogram as well, as discussed the other time, yeah, countries they produce antibiograms from the ongoing AMR activities in the facilities, which is the lab-based, not the in vivo, the in vitro. So when now they see antibiogram from this page, then it may cause some sort of yeah, there could be differences, I do believe. So I think explaining it here, what in vivo antibiogram is and how it's different from the in vitro, will be helpful.
That is, we thought together and we talked. Yes, we will add in vivo antibiogram for the by quantity by infectious syndrome. But we will put this point. We do not say that you should use that. This is our idea based on this data. Anyway, the last decision is with the doctor. Not we are saying that everybody have to use that. This is some suggestion. That is correct, Tamsla. Okay? Yep, we will do that in this way. Okay. Any other? Yeah.
I think there is ample evidence on the ground. So especially as you said, rightly said it, the service providers, the doctors, should use the evidence day to day. So we should promote that one. So they should be aware and they use it as well.
Our problem is that how we can send out microbe for the doctors. I know that they are very knowledgeable. They are very good. They are reading many things. It is your job in the country that introduce this to the doctor. Please look to that doctor. It is good. Sorry? We had this experience. But anyway, we can add as an app. Janet, can we change this to the app? But it is something that we can think about. No, all the microbe and antibiogram.
I think maybe we need to get to a point where the person in the country or the person in the AMR national system who, or in the hospital, who sees the antibiogram or produces it in the lab has a mechanism through which they can share it with the doctors. Unless we're looking at the antibiogram at the national level, but I believe that given how the doctors' day-to-day activity goes, how busy they are with patients, I doubt they'll have time to look at the antibiogram. But I know that in some hospitals, there is a weekly meeting to brief doctors on what the antibiogram looks like, what the AMR situation looks like in the ward, and supported by the antibiogram, and then it informs doctors of what's going on and how they can then treat patients. So maybe it can be crystallized into maybe a weekly or a bi-weekly update or a monthly update.
Thank you.
Yeah.
That was very good. Okay, we have,
online-
sorry, we have Professor Sabiha
Yeah. Yeah.
and
Does?
Hello. Hello, everybody. I wish I could be
Yes,
in
it
the
does.
room. Can you hear me?
Yeah, I'll come back to you.
Professor Sabiha, you are,
Hi, Professor Mohsen. I wish I was there in the room. The conversation is so good. I just wanted to speak on the comments about the antibiogram. I mean, my concern is that they are very useful, but at the moment, the antibiograms are not based on representative AMR surveillance, especially in low and middle income countries. So as we get more data from the Fleming Fund surveillance, as well as more work that is being done, then we will be more confident to use all of these in terms of patient management. But for the moment, I think it should be for information purposes, and you quite rightly say it's ultimately the decision of the clinician to make the call on what to use for treatment. But I don't think we can rely on antibiogram generated from this study for the moment. Because we know that it's not representative. If you look at the MAP study, for example, like 1.3% of our African labs are actually doing bacteriology. So that's my concern. And thank you for the platform.
okay. But, yes, thank you. Thank you for this point. But you should know that we get all of the Fleming Fund data and input in our process. In this project that we are doing is between Wellcome Trust, Fleming Fund, IHME, Oxford University. We are thinking that almost 80–90% of the data that is in the world we used. That is whole. And is not something that we stop this year. We will continuously work on adding of the data. Maybe we can talk more detail in any time that you have time, we can talk about that. But your point was very important. Okay, yeah.
Thank you very much. I think I wanted to make a comment first for the policymakers. Like, this document is very good, but I think there should be one specifically for policymakers that is even more simplified, because especially if, for example, not only the minister, but maybe you want to now, and you have opportunities to discuss with policymakers, senators, they are not even medical, so they might not even really, and they are the ones that will really push for funding. So if it is possible, either from GRAM directly or supporting countries to produce a simplified versions, and as you've said, talking about the economics and the numbers and comparing it with what the challenges that countries are currently facing. Like, I remember the first GRAM study, we had one like this. I interacted with one, I think 2022. It really showed a picture showing malaria, HIV, TB compared to AMR. And when this was presented to the Director General then and even the minister, they were like, oh wow, AMR is now. So I think having that comparison and also the financial parts will be good. The point about clinicians, I think that clinicians do not have time looking at microbe. They have a lot of work. but if it is distilled into a format that will help the hospitals work on their guidelines, and then the country can now, or through medical training and also regulatory bodies, for like doctors are supposed to have continuing medical education, pharmacists, laboratory scientists, then those groups can be better engaged to include these tools as part of learning for health workers in the countries.
Thank you. Thank you. Let me go through your comment. Make it some version of that is simplified. That is very simple. Maybe we can change first page as a summary and very simplified, and then go to the second, third page. Gisela, mother of this letter is Gisela. Yes. That is very important. Thank you. Second thing, we intentionally dropped this graph that you said, because there is a discussion between how many deaths happened underlying cause and how many intermediate cause. Usually AMR deaths is intermediate cause. Then when we compare this for the people, for the malaria or HIV, for the other malaria and HIV gang, saying that, oh, you added intermediate cause and compared with our result. This is wrong. Then, oh, and now is here in this way, that we put in the page, thank you. Yes, in the page 3, we didn't include in the underlying, but it shows that, okay, it is after what? We have lots of enemy and lots of friends. Then we have to be very careful. Okay, that is very good. Any other comment? Yes.
Thank you, and for the presentation. I'm from Kenya, and also happen to be a GBD collaborator. Now, there are a few issues that, in terms of policy, that probably need to be refined better for policymakers. For example, the translation of this data to something actionable. This is what has been produced here is good, but a few things would come up. For example, the methods need to be clear, simplify the methodology so that the policymakers can also look at it. The other issue, of course, is the linkage between cause of death attribution due to AMR for policymakers. When you're saying it was a road traffic accident, but now you're attributing the death to AMR, that is something that also needs to be refined. Then the antibiograms, since these are global estimates coming down to country estimates and all that, we know for wider, broader national utility, say, if you want to do procurements of antibiotics for the country, this will be quite okay. But there are in-country differences, those regional differences which may not be picked up because of the lack of representativeness of our national data. So this should still remain a guide for the clinicians, but eventually they still have to make those decisions at that level. But clearly there is utility for it. As the data improves, when we make our surveillance sites more representative, this will become better.
Thank you. Thank you. Let me add one other point that our method calculation here is not calculate global and then distribute to the region, super region, country. No, we calculate country by country. Country is in the data. And yes, you are correct. For example, I don't have a lot of data for Zambia. Zambia is an example. I don't remember that we have. But we borrow a strength from the neighborhood country of the Zambia. And by the end, again, we will say that, okay, this is just suggestion. It's based on the limited data. Decision is with you. Just we wanted to give you some suggestion. Any other? Is there anybody in the? Oh, yeah.
Yeah, I think anti-biograms should be dynamic and as much as possible specific to the health facility and even to the wards. So maybe the one we are discussing here, the national one, maybe it can guide procurement as previous speaker is submitting, but the whole goal of antibiogram is to guide empirical treatment in the absence of laboratory testing data. So yeah, even in country we are doing the tertiary hospital antibiogram should not be replicated to the general hospital. So the general hospitals, they have to generate their own antibiogram. And today's antibiogram is not, maybe may not be similar to next time, and the data has to build and to refine the antibiogram. So I think we need to take that into consideration. And in this country biogram that you have in gram, that you will bring it more, I do see the importance of putting the disclaimer like it is in vivo and yeah, for information purpose and not necessarily for guiding treatment. Thank you.
I agree with you 100%. And one of my goal for the adding antibiogram is that bring doctor to the discussion. They can send a letter for us, God damn it you, what is that? It is wrong. This is the best for us because we get connection with this doctor, we will bring him to the more and more discussion and getting help from them. Yes. Do you know, we are alive based on the comment that we get from you, good or bad. It doesn't matter. You can say all of them is useless. I will ask why. How I can do that it will be useful. And then we get you involved in this discussion. This is something that I did from 2013 in these 12 years in the different countries, in the many, many different countries, and get idea from the people that, okay, what is the correct thing? How we can correct everything? Okay, any other comment? You are here until 12. Then don't think that, okay, we don't have comment, let's go. Yes, you are here. Officially, Janet said that 12 you can close. Okay. Any other comment? You can go and take your break and anything that you want. Tea. Doctors, I want to get your comment. Yes. This is very important for us that you that working in the hospital for many, many years say to us that how we can help, how we can improve the story of AMR. Anything that you want to say?
It is a very complicated question you've asked, as you well know. And I am at a disadvantage having come late to this conference. My concern, I'm just looking at the data from Kenya. And one of the pages here, I assume this is true for the other countries, because as I was looking at this, it doesn't match what I'm seeing at MTRH. For instance, the respiratory pathogens which cause the most death is actually Streptococcus pneumoniae after TB. TB, Klebsiella pneumoniae, and then Streptococcus pneumoniae, and that doesn't match what I'm seeing. TB for sure, and Klebsiella for sure. I'm seeing very little strep pneumo. And so I'm wondering where the data is coming from. And it says here, data sources for Kenya. In total, 520 million individual records or isolates covering 19,513 study location years were used, blah, blah, blah. And I can't get information in my own hospital without extensive effort. So I guess I'm curious as to where the underlying data is coming from. And I only use that as a point that I think the biggest challenge to come back to that pyramid that our first presenter made of data. Wisdom at the top, knowledge, something, and data is to get data from multiple sources. And as someone from, I believe it was Tanzania, pointed out, we're collecting them not at Sentinel sites, but we're collecting them at places like where I work, which is a referral center. So the only concern I have about the data here in Kenya, and I would assume this is true for all the countries, that Fleming Fund is, and SEMA and the other organizations in this coalition are putting together, it is not, I am not being critical of the data, but I do think that we need to be very clear, is that this data is pinpricks of light against a very dark background, rather than really thorough data. And I don't see anything in here that really sends a note of caution to say, we base this off of very small sample sizes.
Thank you. Thank you so much. Thank you. Let me just, I agree with you. Let me just make some suggestion. First, this estimation is based on the general hospital and referral hospital. And we corrected referral hospital to decrease the bias of the referral hospital. Automatically cannot be same as referral hospital. That is correct. This was intentional. Because if we wanted to look to the referral hospital, we had a big bias. But now we do not have. And you raise this problem. Thank you. We are looking to the whole Kenya. For sure, in the referral hospital, you do not see streptococcus pneumonia, because in the streptococcus pneumonia in the general hospital, get the treatment and go out. No problem. You will see very bad pathogen. That is correct. But my point is that how we can work together to fix this problem, that have a better data, how we can get this data that is in the table of our friend in Ghana and put in this thing. We know that there is tons of data in your system, but we don't have, because you don't share. For the many reasons you don't share. How we can get that? Is it possible that, let me say in this way, make a one general hospital in each county in Kenya to send data with the inpatient situation, what is the diagnosis, what was the other diagnosis, main diagnosis, other diagnosis, what is the lab result, and what is the, again, discharge situation. If we have that, it is the best data. But it is something that we need help. Anyway, how we can get data, improve the result, it is very important. We don't know. You are correct.
For him. So the problem around data is something that we see across a lot of countries, both in Africa and in Asia and in the Caribbean as well. So from your own experience, I'd just like to hear from you, to what extent do you think that the problem with data arises as a result of probably how poorly we capture data or disjointed data capture systems? What do you think is the main issue when it comes to our data?
I keep getting the hard questions. So just as background, I actually came to Kenya after 4 years in Southeast Asia. And much of that time I was working in microbiology and antimicrobial resistance, so I'm familiar with the Asian side of the problem. And obviously, like Africa, Asia is a complex place with different countries having different approaches. I would say, broadly speaking, very broadly speaking, there are two issues. The first issue is the quality of microbiology data. So this is sponsored in part by Fleming Fund, is this correct?
A little.
Yeah, a little. So I'm very familiar with Fleming Fund, and with programs like Fleming Fund, you have, and in Cambodia, I worked for a program that was sponsored by the US Department of Defense. As everybody here in this room is aware, the US government's support of surveillance systems like this has undergone a complete change in the last 2 months. But the goal was at the trench level. And so it was to get microbiology labs to work. My personal feeling is that is an incredibly inexpensive, high optimization strategy. If you throw out MALDI-TOFs and you throw out Vitek machines, and you teach people how to do basic microbiology the way it was practiced in 1940, cost you $50,000 a year to run a good lab in a regional facility. All you need to do is train people. Many donors want to give Vitek machines and MALDI-TOFs because they look pretty. The problem with the MALDI-TOFs is they work until they stop working, and then you have to fly somebody in from Bangkok, Accra, Lagos, which is fine if you can afford it, but most of these systems can't afford it. So one thing is an issue of quality, sustainable data that comes at a low cost. And I actually think the solution for that is right in front of our collective nose. The second issue, which I think is particular to Africa, and it may not be true of all African countries, I'm far from an expert. I am a new arrival in Kenya. I've lived here for 7 months. Is there's some nervousness around the open sharing of data and the concern of how it makes a system look. I am an American, I have an American attitude, which is you take a look at data for quality improvement. It's more sensitive here in Kenya. As a visitor and a guest, I try to be very sensitive to that sensitivity. As an outsider, I do think that's an issue, and I think we have to overcome the issue. I would guess that's true at least of some other countries here. Those, I think, are the two big issues.
Thank you. Thank you. That is too big issue. But anyway, we are living in this world, and we have to fix our problem in this world. I don't know why Pentagon gathered this data. God knows. We don't have this data.
Can I tell you why the Pentagon? Sorry, I should have explained that. So, I mean, this is actually one of those very unusual situations where the United States Armed Forces do something that's in everybody's best interest. I realize that is not always the case. The goal was improving microbiology laboratory surveillance systems because they were concerned particularly about melioidosis, Burkholderia pseudomallei. So they realized that by improving microbiological surveillance throughout Cambodia had a benefit for the United States because, and for the security of the world. So I wasn't working, I'm not a spy, I was not working for, in high-tech bioterrorism labs.
Okay, unfortunately, we do not have this data. Unfortunately, we do not, many countries, especially European countries, due to the security problem, do not share their data. And world is going in this way, segmented world. Maybe we are crazy people that try to make something that everybody can use that. But anyway, we need any help, any idea from the different group to get to be winner on in this segmentation. Now Europe has own process. Africa slowly go to their own process. Okay, then what will happen to the world? What will happen? Then I think that we should go in this way and find a way to get better data and include. That is my goal. Yes.
Yes, a few final things in terms of what can help countries. One, if the report could be more granular, because at national level, if you take Kenya, we have different ecological zones, so we expect different infection patterns and all those drug use patterns. The other issue is, could we adjust for underlying causes of death? And finally, I believe as we refine our surveillance strategies to reflect what you advised about both the inpatient and outpatient antibiotic use, then the data will be more representative.
Okay. How we can get better data? Now we have, maybe I should say that if you read behind of this page, you will see that we have the biggest data that it is possible so far. But we know that it is weak. It is not enough. It is not to the point data. I think some friends are here from Africa CDC. Africa CDC. Okay. Anyway, we need help from Africa CDC. We will have, after 2 weeks, meeting with the Europe CDC. We are meeting with the WHO, and we are trying to get this data and improve this result. if you think that it's work, or we have to stop working in this world. What do you think?
I think that we need to improve the data collection specifically for the clinical data. I think that is the part which is missing in many countries. I also think that in many Fleming Fund projects, country projects, they are starting collecting burden of disease data for some of the healthcare facility in the countries. Maybe I think that by the end of the years, maybe something that we have like more, as we discussed, demographic, clinical, and lab data coming from more of Fleming Fund countries.
Any other point? Yeah.
Thank you. So I think my point is around the issue of generating this data we're talking about. Looking back a couple of days when we're talking about the data that required for us to do some of this analysis, looking at the associated and attributable burden, I think one critical thing that has been emphasized is the lab data. And I think sustainability to generate that lab data, microbiologics lab capacity, sustaining that across the continent, that's one of the fundamental challenges we have. There are many countries that may not have that capacity to generate that lab data. And so that alone is a problem. That alone is a problem. And I think when the doctor was speaking earlier, he talked about investments coming, but focusing not on sustainable mechanisms, sustainable platforms, but things that are attractive, that tend to catch a lot of attention, but then in the long run, there are challenges with sustaining these platforms. And so I think that's one of the fundamental problems that has happened across many countries. Now, several countries are having support through, for example, the Fleming Fund and other partners to support what is happening in terms of microbiology, but can that be sustained after these projects, after these funding support? So those are some of the issues. So if that is a challenge, you definitely will not be able to get the right data. You will not even be able to get data from some of these countries. And I think that's where the challenge is. So I think we need to also begin to think in the direction of sustainability in terms of microbiology lab capacity, so that you can have a constant flow of data that can inform some of these things. Over.
Thank you. Thank you. Let me add one thing then, Bo. Do not forget that Fleming Fund is not just the source. We have many other sources. Galaxy. 96 countries, Ben yesterday said, 96 countries should take data in the Galaxy. And Galaxy is improving. And Galaxy is global and is publicly available. Okay. I know Fleming Fund may be vanished. Yes, you are correct. Fleming Fund, based on all the situation that we have, maybe will vanish. But we have WHO, we have GLAS, we have many other sources. There is a big job that Wellcome Trust is doing. Anyway, we cannot say, okay, let's die, everything is finished. No. No. We are not this group that say, okay, let's die, everything is finished. No. Okay.
So, thank you very much. I think one other comment I wanted to make is, how do we also plug this into like health system strengthening, particularly health financing? One thing that I think a lot of people are doing in Africa is that sometimes we look outwards, but we can maybe not all, but finance some internally. And I think AMR, we think AMR is this program out there, but it's within, I think as has been said, it's within the health system. If a country is responding, you will notice that their health system generally is working. They have the systems already to collect information because it's health data that you're actually collecting and then seeing how patient outcomes are from health data. So I'm just thinking, how can this also help? I really like the cost utility part, because is it possible for countries to now start doing that pathway and see, okay, if we do strengthen our health financing, universal health coverage, is this a policy that will help us in the, I know it will help, but maybe showing those numbers or showing that to policymakers will help. But I think we need to start looking at financing our health system from the resources that we've had in the past and somehow we've put in the back burner, and that kind of bring it forward, and also with other sources that are present or available.
Thank you. Thank you.
Yeah, I think she's partly addressed what I wrote on my book. Looking at quality, I think the issue's got to do quality, quantity, and then sustainability, where the health system angle also comes in. Basically, if countries are able to now integrate their AMR issues better into the health systems, then we can somehow assure ourselves of continuous provision of the kind of data that we need to make informed decision. My other issue has got to do with the introduction of automated systems and then the manual systems, as my brother said. I'm not a microbiologist, but a little I've seen going around sometimes, you know, these systems, the biomeros, the BD-tags, some have also been mentioned. They are quite specific. And what we see is that when they are introduced to the health system, cost becomes an issue. Aside the technical support that is given when the systems break down. And the health clinical data, lab data, for instance, once the affordability issues come, the patients not be able to afford, or these culture bottles, black water bottles get stocked out. Then the lab components to inform treatment, that data becomes non-existent. We have an example, one teaching hospital, which was supported by, I think, Fleming. And because there was one particular lab, what was the name? Reagent, which was not available to certain things. For the whole year, they didn't provide a single data on AMR. And I think we should start looking at the country level, how do we maintain the bench work, the traditional way of doing things beyond automated systems, to continuously look at how data, look at the quantity and the quality of data that we are producing beyond the automated systems. Because, I mean, health systems do not cover, health insurances do not do total full cost recovery when it comes to black cultures, which is quite expensive. So we should be looking beyond this automated system and how best we can sustain the provision of lab to support clinical decisions when it comes to infectious disease treatment. Thank you.
Thank you. Thank you. One second. I want to open one other part of the discussion. So far, we talked about the human. What about animal? What about climate change? You are seeing that now many hemorrhagic fever, like Congo fever disease, is increasing in many, many countries that we didn't have. Now we have. Is it big effect on the human also, or in the bacteria, sorry, or it is just in the virus that is transmitted by the insect. And also, how, okay, go to the in this way, after your point.
Thank you, Dr. Moshe. You already raised one of my issues. Actually, our concern should be One Health, that's environment and also plant, animal, human, everything, to have a comprehensive picture of the AMR. My actually first question, I mean, comment is on data sharing. This is very important. Here we are talking about these 14 countries, maybe Flaming Fan supported countries. In Africa, there are so many, 55 or 54 countries. Last time we had a problem to generate African Public Health Intelligence report. During that time, there was an initiative to ask all member states of African Union at least to send their report to Africa CDC, like glass system. So that is not really materialized. If we are not doing that, still we'll have a problem of, having data to generate for policymakers or for whatever for any purpose. So I think all of us have to advocate this. There needs to be one platform of data sharing for African countries. I think this is my, if it is possible, because data sharing is one of the biggest challenge to do whatever you want.
Perfect, perfect. Sorry, let me sit. I am older than all of you. Okay. Let me say, you think that Africa CDC should do that, or WHO, African WHO? Which one? Afro. Yes. I think that, again, because if we do by Africa CDC, North Africa is in the AMRO, Sub-Saharan Africa is in the Afro, then they will not do the good connection. Okay, we will have this discussion with the WHO. Fortunately, Janet is the perfect person. No, she's doing a lot. When you hear from what is she doing, you cannot believe that. All of the things. Janet is working with the WHO, between WHO and Wellcome Terrace, to make better process of the gathering data. We are doing in the different way. We are a lot, and we are not ready to die. Okay, let's come back to the animal, One Health, animal, sorry, I will come. Yes. One Health, and discuss, and also the climate.
Yes, so I think that's a very important point. It goes back to one of the earlier comments about us integrating the approach, this AMR approach, and not looking at only bacteria. Because if we look at it from the perspective of AMR, then we understand that there are other diseases, viral diseases, and all of that come into play. And I think that approach is the right approach, because if you strengthen the human component and the animal component or environment is still weak, you are not going to achieve what you seek to achieve. A clear demonstration of that, for example, in our country, the last JE we did, which was last year, we saw that the human side in the scoring did very well, but the animal angle was not very strong, agriculture. And so as a result of that, the JE scores were brought down because there was weakness in one arm, and they are considered collectively. We're happy that the One Health platform is being established in many countries, and the One Health technical working groups, which also cut across animal, human, environment, are also being established. And that approach is also helping to ensure that AMR is being tackled appropriately. So I think it has to be a comprehensive approach for resource leveraging available resources and ensuring that we achieve what we seek to achieve in terms of reducing the burden of AMR.
Yeah.
Yeah, one of the key intervention supports being provided by Fleming is to support the One Health approach. Yeah, when we see the different sectors, like the human health is way ahead in terms of implementation of surveillance activities, different funding streams, like the HIV, TB, and strengthening all the health system. But when it comes to the animal health sector, I do believe there is no much resource to strengthen the surveillance system, and when it comes to AMR in the animal health sector, for example. So I think the funding support coming from Fleming is trying to strengthen these areas, which starts from infrastructure development, availing the laboratory services to do active surveillance and passive surveillance. Then we can have data in the animal health aspect. And having an integrated approach, like, because this is a One Health problem, having integrated surveillances, like I can mention in Swatini, there is now an initiative to do the WHO tricycle protocol for the ESBL E. coli surveillance. And there are other integrated surveillance plans to do. So such activities should be done, and there must be a support like Fleming and other sources. The key issue is then to have that collaboration among sectors in country and the data sharing. I think you are saying the data sharing at country to global level is a challenge. Maybe also country level data sharing is not easy. There must be that collaboration in countries as well. Investing in surveillance activities, generating data, then that data has to make meaningful in a One Health approach in country. Then I think platforms like the WHO Glass, countries has to use WHO Glass for the human health surveillance. And also INFARM is coming, FAO, similar to the Glass for the animal health sector. Probably they may include also the environment, but that's also on the pipeline. So strengthening country level data generation and sharing and global sharing through the different systems might be the way to go. Thank you.
Thank you. Thank you. That was a very important point, that we can have better data also from the animal side, from FAO, that, okay, maybe we can get, and maybe this is something that we have to start to discussion about that. But how we want to include that? Do you know, we are specialists to the work on the human. Then we have to learn knowledge how we do for the animal, and how is the interconnection between human and animal, and interconnection between human, animal, and climate change. That is the biggest challenge that soon we have to go through this challenge. Okay, thank you.
So I think one of the things that is very important, and I think WHO and other organizations that supported this, is selecting primary pathogens. Because I remember in 2017 when Nigeria was developing its national action plan, we were having this discussion on how do you link human, animal, and environment, and what was used to link them primarily then was the pathogens. So selecting some pathogens that are important for agriculture and then humans. But I also think there's the part of economics, because in human health, people are going to hospital for health, like for the sake of well-being. But what is driving the agri sector is money. So this sometimes affects even sustaining surveillance system. Because if I'm ill, I can go to the hospital. But if a chicken is ill, someone else is taking the decision. And the what is driving it is economics. That is just it. So how do we also depict the fact that if we don't do it correctly, we might think we are improving the economic status of the country, but we're actually depleting health. So I think that economic part of the agri sector might also need to really come out, how we can, the economical impact of, or the economical impact, or the impact of AMR on the economy. I'm not sure, but in the agri sector, economic is really driving how people are interacting with antibiotics and using them, especially for food production and all that.
Perfect. Thank you. Yeah.
Yeah, thank you. I am from the animal health. As it has been said, the animal health is under-resourced and we have not that much data. But from the last 3 days discussion, sorry, I am saying if we can take some lessons, for example, preparing of antibiograms for the animals. In Ethiopia, we have been working for the last 5 years, and we have some data on some pathogens, Staphylococcus, E. coli, and Salmonella. So I'm looking for some kind of support, how we can design the experience from the human side as an antibiogram, and if possible, policy brief. The data, usually in the animal sector, we don't have the outcome data. The setup is a little bit different. It's more of the public health surveillance data we have. From the clinic or what we call hospitals in your case, the link is not the lab and the clinic is very weak. So data from diseased animals is not much, but still we have some data. So I'm looking for some kind of working together in that aspect. Yeah, thank you.
Okay, thank you. Okay, this is a new area. Maybe next year or next couple of years, we can add some interaction between human and animal, some interaction between climate, human and animal, and for sure we will keep our microbe because it is very important for the public health and for the people that working in clinic. But maybe we have one other part of our microbe that it work for the animal. I don't know. All is depend to the world situation. Unfortunately, segmentation in the world and some not good idea and process in the world put many researchers in the hard situation that I hope that we can fix that. Okay. Any other comment, question? Good thing? Yes?
So this is about more about understanding, when it comes to data from the glass, and in our experience so far, there is a tendency for enrollment of higher centers, and I know that you have been adjusting that with the tertiary care versus non-tertiary facility lab data. Will it be useful if there is a, for example, countries do some analysis every year, but in terms of trying to classify the lab based on the level of care and identifying the patterns, and maybe some advocacy for countries to include more of secondary care facilities in their glass network. Will it make a difference in terms of the work that you are doing, in terms of gathering data to improve the modeling? Or because you are already adjusting that, it will not make any difference? Because this is something which we are also trying it's difficult to, because countries want to have better data, but better data, they assume it comes from the tertiary care lab, which has facility, but there's always sampling bias, as very well explained in the morning. So this is something which,
Very important point. Can GLAS replace AMR and micro? Based on my idea, no. Because GLAS is prevalence of resistant. Nothing more. If you remember, we showed to you that AMR as a comprehensive action plan have to have 10 components. One of these components is prevalence of resistance. One of the biggest components is, okay, what is the distribution of the pathogen in the different infectious syndrome? Do you have in GLAS? No. What is the relative risk of the dying with the AMR compared with the no AMR with the same infections? And there are many, many components, especially pathogen distribution. If we stay just GLAS, is perfect, super useful, because can improve a lot of things in the AMR. But it's not all of the AMR, because the biggest part is, what is the pathogen distribution? What is the infectious syndrome distribution? What is the outcome? Then, okay, we have to work together, regardless that you are WHO, this person is Africa CDC, this person is University of Washington, this person is Oxford, this. Anyway, we have to work together. This is, AMR is an international problem, and we have to fix it internationally, all together. That is the maybe most important message that we can have for everybody. Okay, don't stay, okay, I will fix with the, this data that I am gathering. No, you cannot fix it. It's come to this story that our friend yesterday, 2 days ago, from Ghana said that, okay, many people are saying that AMR is not a big problem. Yes, if you just look to the pathogen and antibiotic, no, it is not a big problem. But it is a big problem. We show to you that every year in each country how many people die with the associated deaths with the AMR. And, okay, this is our job, to continue this way. You are AMR, we are AMR, we are same gang, then we will fight for our gang until the end. No stop. It is something that it made me very happy to see this talented person in the Africa interested to this topic and working in this area. And my suggestion is that if you do not have any question or any comment or any good thing, bad thing, I ask Janet to come here and close the workshop. Because anyway, when you are working with Janet, you understand how much she is capable.
Thank you. Thank you, Mohsen. I really appreciate your kind words. And I think that before I close the meeting, I think it's important to recognize the presence of Dr. Thumbi Mwangi, who is the director of CIMA, who are hosting us today. So I think it's only proper that before we close and end today, that Dr. Mwangi would come and say a few words. Please, Dr. Mwangi.
Thank you. Thank you, Janet. Mine is to thank everyone for attending this, I think, really important workshop. And I had the chance to listen on the first day and today. And that's like what you're doing is part of what you desire to see done also in countries. And this is, I think, is an exciting opportunity for us. I want to say a very big thank you to the people that sit back there. Yeah. I know sometimes we forget them, but they make it happen for us. And so I want to thank you very much, the SEMA team, for doing this. And to Janet, obviously, for connecting us to the University of Oxford and IHME. And one of my colleagues came here on Monday and said, this is a very different crowd of people from what we normally train often. And I said to him, the reason is these are the people that make things happen in countries. And I think it's for me very gratifying to see the people that are responsible for policies or are very connected to their countries come into this kind of detailed analytics about AMR, because then it means we are going to use evidence in our generation of policies and programmatic actions. And so for that, I really appreciate you as well from all your countries, and to say we are more than happy to collaborate and continue working with you, and looking forward to many other opportunities to work together. Karibuni sana SEMA. That means in Swahili, you're very welcome to SEMA into Kenya.
Thank you. Thank you very much, Dr. Thumbi. So from my end, I just want to say really a very, very huge thank you to everyone in the room. First of all, for honoring the invitation and to come here. I work with Welcome, and Welcome is a funding organization. And the basic business of Welcome is to fund health research globally. But it cannot happen when we don't work with country teams. And as most of you whom I have interacted with know, my passion is in seeing change happen in Africa, and in seeing things happen in Africa through encouraging Welcome to put funding where it's needed. It is Africa that has the highest burden of AMR, and of course highest burden of other diseases as well. And so it's really important to me and very close to my heart that I can work with Welcome to bring together people from African countries and support us to learn how AMR burden data, which Welcome also funds the analysis of, for us to come together and learn how our data is analyzed. So we're not only giving data for analysis, but we're also being shown how our data is analyzed, and we're also learning how our data can be used to inform policy. So there is definitely a very, very long list of people to thank, but I'd really like to thank Waithera and the lady sitting next to Waithera, Dr. Jeanette, and of course Dr. Thumbi and his team for supporting us. I have always worked with IHME and Oxford to put the GRAM study together, but I was always worried that we are analyzing the data, but we are not working closely with an organization that is based in Africa, who can also be involved in helping to analyze the data and translating how that data is put to use in Africa. And so I'm really glad that we have now started a journey of working with CIMA, and hopefully we can collaborate well enough that in time, the center of gravity of how AMR data is analyzed is shared between IHME and CIMA, and between Oxford and CIMA, so that we can look forward to more training courses, maybe eventually moving virtual to something that is run on the continent. Because it is only when we know how to analyze our data, then we can understand it better and put it to use, and then help our policymakers as well to understand that data. So that's something that's been my vision for a long time. I'm glad that in the 6 years I've worked with Graham team, this has now come to happen. So that really, really pleases me. Before we end, I'd also just like to thank the Kenya team. I'd like to thank Evelyn, Dr. Evelyn Wesangula and Dr. Tanui for also agreeing to become part of the policy session this morning. It was very important because they are the experts who know how these things should happen at the country level. And so thank you, Dr. Evelyn and Dr. Tanui, for taking your time and to be able to attend the whole meeting and all the sessions together. So this is for me the first time in this job that I have been able to put a higher number of African countries in a room together. I know we are still missing Somali, we are missing Tunisia, we are missing Morocco, we are missing Mauritius, but I hope that with the right contacts, next time we'll be able to include more countries and of course be more inclusive of African countries. So I did share my email somewhere on my presentation yesterday. If anyone has any feedback or any information that you'd like to share with me on how we can improve this going forward, please feel free to email me or just come to me later and I'll share my contact details. I'm very open to how we can do things better and improve things for the African continent. So thank you very much. I think I've covered everything. And to the Oxford team and the IHME team, special thanks from the bottom of my heart. We have worked very well together, and I hope that we can continue to do this for another level of the Graham work. So thank you. And the hotel team as well, thank you for all the catering and the hospitality. We really appreciate it. Yeah, thank you. So, and in the spirit of equality, I think it will really be good to have at least a representative from 1 or 2 countries also come and tell us what you think about the session and what you have experienced in the 4 days that you've been here. So that it's not just us talking, but we'd also like to hear from the countries because it's also for you. So I will share the microphone to anyone who wants to talk. Come on, don't be shy. Or I will nominate. Okay, I will nominate Ethiopia because I think Ethiopia has the highest representation in numbers. So
you should come here. No, it is not serious. It is very serious. Okay.
Okay, thank you, give us for this opportunity. As an Ethiopian team, yes, we are represented in large number. We did it because we wanted to include animal sector also, because I don't think any country is bringing the animal sector here. So we brought also the animal and the human sector to see how One Health can be really implemented in our country. So we are doing really a very great job in our country to bring all these sectors together. And this workshop really is an opening, especially to develop our data, generate data, quality data actually. We are having data, but we have to generate this data to relevant to policymakers, as Moishan said, to clinicians, to hospital managers, to everyone. At least we understand to whom is this actually policy should be targeted. Even our data. In fact, we produce antibiograms every year, and we also share to clinicians. Actually, it's not in the morning session every week. You cannot produce antibiogram every week or every 6 months. Antibiograms will be produced annually. It's not really something that you do every time. So this workshop is really very helpful for us because we are preparing now to disseminate our data next April to the annual. We have annual review meeting. That's what we call it. So this workshop really helps us to really customize our data relevant to those audiences and further improve our surveillance system and also other, AMR components that are important to combat AMR in our country. So I'm very happy, and also my teams also will be as well very happy So we are grateful to be here. Thank you very much, Dr. Moshin. He is our supporter in Ethiopia. In fact, we have a very long relationship with IHME. Thank you, Moshin.
Thank you. Yeah. Thank you very much from Ethiopia. And I think we have various WHO representatives in the room as well. So I will choose one to say something. Don't look aside.
Come here.
Sipiwa, I know it's your doing. She was pushing me that I have to say something. Okay, hi everyone. My name is Impela Chibi from WHO Zambia. I'm actually, this is my second month with WHO. So upon joining there was just a lot of things that are coming. This one actually is on my #1 list. So just pushed to come for this meeting, and I've really benefited. And the way it was organized, I think it has met my expectation. And I think and believe that every one of us has actually benefited the way I have. I've met people, we've interacted, and this, for me, it's been a learning event, not just in AMRI, just the way we are actually interacting globally. And thank you to the organizers. I know meeting Janet, we've communicated via email. So just attaching now the face to the name. And as WHO Zambia, we are actually taking this very serious with the team, Joseph there, Dr. Chizimu. We are making sure that we will not leave any stone unturned. And I would like to say to all the countries, please, let's be on board, let's do this. I think if we work together with this information, we'll be able to achieve what we need to achieve. Thank you.
Thank you. Thank you very much, Dr. Mpela. So I think that in the spirit of equality again, there's nearly 20-something ladies in the room. So I must not be the only one who comes to say something. So I'm going to choose somebody who I have not seen say anything since we started. There's going to be a lady who has not spoken. So I'm looking around. Yes. From Namibia.
Okay, I'm from Namibia and I'm more on the lab-based. So we analyze the data and share it with our Ministry of Health. And I actually learned a lot, especially the fact that we don't only need to consider the tertiary data, but we also need to strengthen our peripheral lab so that we make sure that we have quality data that we need for policy making and to combat this AMR in the country. And what else? Yeah, I'm really happy. I know that this is my first time actually hearing GREM. Like it was, I only found out when I got the invitation, and I'm glad that I'm involved because I'm the AMR focal point from the lab, and we are the one that validate the data before we send it out for analysis. Thank you.
Excellent, excellent. That's really encouraging to hear because there's always a first time for everything. So it's really good to know that it's the first time you heard about GRAM and that this is now an open opportunity for your country to be able to engage further. And that's why I think going forward we need to include more and more African countries in this family of countries that work on GRAM and work with GRAM data. So before we end, I think it's fair to also hear from the people online. So I'm not sure if Dr. Letitia Gahimbare, are you there? Can you hear us? Yes, Dr. Letitia, could you please just now close for us, please? Thank you.
Yeah, thank you so much for the opportunity. I apologize for not following everything because the sound was not good. Despite that I tried everything, but this happens. Maybe it was a technical issue. And I'm happy that I could participate. And we even happy to get a summary. I could not contribute because I wasn't really hearing a lot from my end, but I could see some of the presentations and appreciate the audience, some of their interventions, which are very, very wise and insightful. And I look forward to collaborate with you and other participants. And I want to appreciate that also that we've been using the grab data in many of our reports and talking, and through the glass that we promote, we are trying our best to encourage countries to collect data, to report through glass. Congratulations to all the countries, and still have issues with representativeness of data, but more and more as the countries reports and as they are sensitized on the quality issues, we hope that small by small we will build the system. So thank you so much for the opportunity, and I look forward for more collaboration. And I wish you all the best in this interesting and exciting journey. Thank you so much for the opportunity.
Okay, thank you. So I think we can consider the meeting officially closed. Thanks once again. I'm very, very glad that it's gone well and we are all happy and pleased. And unless there's any housekeeping announcements from Jeanette and the team, any housekeeping announcements? So maybe, I think the only thing is there are people whose flights are much later than the checkout time. What we have done is we have requested the hotel to extend your checkout time. If you're supposed to check out at 1 and your flight is maybe 11 in the night, we've requested the hotel to extend your checkout time to 7 so that you can check out closer to your flight time. So that has been taken care of. And I think lunch is served at 12:30, and so that means we have some time to talk to each other and network a little bit. And of course, following my presentation yesterday, if any of the countries would like to discuss data capture and the data capture tool I presented, feel free to contact me and we can discuss while we're here as well. Mohsen.
What I can say, I said everything. I said everything. I don't have anything to add except all of the slide. All of the thing is in the website of the workshop. You can download it. Please download these 2-3 days because maybe in Seattle they close the website soon. But anyway, one important thing. This is my email.